Now, let's cover some respiratory medications. And in this, we're going to talk about asthma, issues with bronchoconstriction. We're going to talk about emphysema and problems with the alveoli and bronchoconstriction. And we'll talk about some chronic bronchitis. All of these conditions have slightly different kind of pathophysiologic issues going along with them. We've got asthma, we've got COPD, chronic obstructive pulmonary diseases. And with that, under our COPDs, we've got chronic bronchitis, we've got emphysema, and just our everyday rhinitis, right? Your runny nose. These are our respiratory issues, and what medications can we give and administer to help control and control the symptoms of these issues? Well, we've got three kind of big, broad categories of medication that we're going to use, sometimes in tandem, sometimes alone, but we're going to use these to try to control the symptoms and manage the symptoms and the issues of these respiratory issues. We've got anti-inflammatory medications, we've got beta 2 agonists, and we've got muscarinic receptor antagonists. For our anti-inflammatory drugs, we've got a couple different types. One of those is glucocorticoids, type of steroid, and when giving a steroid medication, we're going to blunt the immune response of the body. And this is cornerstone therapy in asthma patients. Chronic asthma patients are typically on some sort of a glucocorticoid if the asthma is chronic enough, bad enough. But we've got Flovent and Rhinocort are out there. These are glucocorticoid medications. So your patient may be on Flovent, maybe on Rhinocort. You may have seen commercials for one or both of these. But when you see these, you know Flovent is an anti-inflammatory and it is a glucocorticoid meant to blunt the body's own immune response to that kind of outside presence that would cause the bronchoconstriction and inflammation. And then our other anti-inflammatory medication category is leukotriene inhibitors. And what leukotriene inhibitors do is inhibit leukotrienes, and through that, they inhibit bronchoconstriction, they inhibit slow down mucus secretions, mucus production, decrease airway inflammation. Again, this is a daily medication. This is not a rescue inhaler. When we're talking about asthma or COPD, these are daily medications. So again, you may have seen these out there. Your patients prescribed on these. Singulair is probably the most common leukotriene inhibitor out there. So you see Singulair, we know it's an anti-inflammatory medication for a respiratory condition. It's not a glucocorticoid, but it's a leukotriene inhibitor. Then we have our beta 2 agonists. And remember, beta 2, if we stimulate beta 2, we get bronchodilation. And in these patients, or asthma patients, COPD patients, we want bronchodilation. So we can give a beta 2 agonist. These come in a couple different flavors. We've got rapid acting beta 2 agonists and long acting beta 2 agonists. For our purposes as paramedics on the truck, in the ER, elsewhere, we want rapid acting beta 2 agonists, so we're going to give albuterol. We're going to give Xopenex sometimes. So you might have albuterol. Well, you probably have albuterol in your truck, but you might have Xopenex on your truck. Xopenex is just levalbuterol. It's just an isomer of albuterol. It's just kind of like a mirror image of it when you look at it chemically. If you don't want to take organic chemistry, then don't worry about it, but it's a lot like albuterol. Looks a lot like albuterol, just a little bit different, just kind of a mirror image of it, or kind of a spun, rotated chemical image of albuterol. They're both rapid acting beta 2 agonists. Then your patient might be prescribed, might be on a long acting beta 2 agonist. And there we have drugs like salmeterol and formoterol. So your patient might be on formoterol, and that's a long acting beta 2 agonist. So Your rescue inhalers, those are going to be your albuterols, maybe a Xopenex rescue inhaler, usually albuterol, but maybe Xopenex, and then your long-acting medications. Patient might take every day. It might be a formoterol or salmeterol, but all these are all beta 2 agonists. It's just some are rapid acting, rapid onset, and some are long acting, kind of long duration of action. Then we get to our third category, third flavor of medications for taking care of these issues, asthma, COPDs. We've got our muscarinic receptor antagonists. So we are blocking, antagonizing muscarinic receptors. And what happens there is we block some of that bronchoconstriction from the parasympathetic side of our system. And when we block those muscarinic receptors, we dry out the body. We don't have secretions, or we slow down, we inhibit secretions. So that includes bronchial secretions. So when we give a muscarinic receptor antagonist, like ipratropium or Atrovent, or something like Spiriva, which your patient might be on. So we've got Atrovent on our trucks. Most of the time, we've got a patient might be on Spiriva. These are muscarinic receptor antagonists, and they are blocking the parasympathetic system. They're blocking muscarinic receptors, decreasing bronchial secretions. We usually give these in concert with a beta 2 agonist. So, like with albuterol, I can give that to open up those bronchi, get my big bronchodilation. I can give this muscarinic receptor antagonist, this Atrovent, to decrease secretions, and I kind of get this 1-2 punch to my COPD patient, to my asthma patient. So not only are we bronchodilating, but we are decreasing secretions and making it easier to move air in and out. As always, if you have any questions, comments, concerns, or cuss words, please let us know.